Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. In 2023, the Indiana legislature appropriated $225 million over 2 years for public health, enabling a massive increase in public health activities at the state and local levels. Now, this did not happen by chance. It was the result of a concerted multi-stakeholder effort to reverse years of underinvestment. Given long-standing concerns that despite strong evidence of the value of public health, it's often difficult to convince political leaders to make it a priority, it seems reasonable to ask, how did they do it? Well, we will ask and answer that question in today's episode. I'm here with Nir Menachemi, professor and Fairbanks Endowed Chair and interim dean of the Fairbanks School of Public Health at Indiana University. Dr. Menachemi and co-authors published a paper in the June 2024 issue of Health Affairs describing the path to Indiana's major new investment in public health. We will discuss what contributed to this legislative victory and the lessons Indiana's story has for other states. Dr. Menachemi, welcome to the program.
Thank you. I'm excited to be here.
So this is a great story, and I'm looking forward to hearing you tell it. Many of us heard about it from a distance, but I want to get a little up close and personal version of it. But before we begin, I think it's important that we set the stage by understanding sort of what the feeling was and what we knew about Indiana's investment and spending in public health before the events that we're going to describe today that you wrote about in your paper.
Yeah, Indiana has not invested a lot in public health historically. We've always been either in the bottom 10 or occasionally in the bottom 5 states when it came to investing in just overall public health per capita or CDC funding per capita or HRSA funding per capita. And so we were starting from a position of really trying to get better.
And as you tell the story in the paper, there's a report on Indiana's public health system that sort of kicks off most of the story that you tell. So I'm going to ask you to describe to me, like, what was in that report? How did it make such an impact? And how did it launch the process? To be clear, it was a process, but how did it launch the process that led to the investment you achieved?
Yeah, so the report, which was actually written up by folks here at the Fairbanks School of Public Health, it was actually funded by the Richard M. Fairbanks Foundation, which is a respected local philanthropy that really has a passion for improving the lives of folks here in central Indiana and beyond. And the report, it's important to mention, was written right at the beginning of the pandemic. So it was published in December of 2020. And it had several main takeaways, one of which was the fact that many stakeholders, including many policymakers, just couldn't differentiate between the medical system, which treats one patient at a time, and the public health system, which is designed to be very prevention oriented. And I think in the mind of many, these were one and the same. Another main takeaway from the report was that Indiana communities underfund public health, not only relative to our neighboring states and the U.S. overall, but we also looked at comparable states, which were selected to be similar to Indiana on demographic and political variables. I think many times we can take exemplar states and try to make apples to pineapples comparisons, but that doesn't typically work. I think people want to see how are we relative to folks we identify with. And so the third main thing we found in that report was that not only were we underfunded, but we were also over-relying on local funds, local tax dollars at the county or city level. And that contrasts with U.S. norms, which typically rely significantly more on state level or federal funding for public health. And so because of that, our fourth finding was that there are lots of areas, majority of areas in the state, where even basic essential public health services are just not available to a lot of Hoosiers. That includes things like epidemiological analyses, emergency preparedness capabilities, the IT infrastructure needed to conduct public health services, some environmental health services, and that kind of thing. And then probably the last finding of that report was that ultimately the connection between poor health uh, and economic development results in a scenario that if we don't improve the population health of people in the state, a lot of the goals that we have as a series of communities and as a state overall in terms of economic development are just unlikely to be realized. Population health and economic development, I think, go hand in hand.
Well, it's a great summary of the report. And what I really like is where it begins, because I've spent a lot of time in front of policymakers who talk about the importance of prevention, and we ought to prevent all these diseases. And then uh, when you have a public health discussion, they don't realize that's the discussion that they were just having. So that's a really interesting beginning to a much more complex story that you describe. So I'm interested in what led to the creation of this commission by the governor that seems to have been an integral part of the process of the legislation that ultimately passed and the budgeting that ultimately passed. Sort of how did it come into being? What did it do? What was it set out to accomplish?
Yeah, so one of the recommendations in the Fairbanks School University report was to create a group to advise the governor and the legislator on ways forward. We recommended at the time that the group be as inclusive as possible, include folks from the local level. Ultimately, the governor did appoint what was now known as the Governor's Public Health Commission in Indiana, and it was a group that involved both locally elected officials. You know, we had a few mayors, county commissioners, some public health experts, some leaders from business, leaders from academia. And this was something that the Indiana Department of Health was going to work closely with. I think critical to the commission's work was the appointment of two co chairs, one of which was a highly respected former state senator in Indiana that was frankly known for his reputation in not wanting to invest government dollars in a lot of infrastructure and a lot of activities, and was really going into it in earnest to try to figure out what can he learn from this process. But the other co-chair was a true national public health expert who's highly respected nationally, if not internationally, but is also homegrown in Indiana, having spent some time as our state health commissioner. And so we had like leadership that understood both the politics and the public health. And in retrospect, that was a really important decision that the governor made that I think enabled lots of discourse that might not have been just as easy to obtain without them and their leadership.
What can you tell me about that's a great observation about the importance of who you pick and who will listen to whom. Um, what was their charge?
I think their charge at the end of the day was to create a set of recommendations in a report on how the state ought to address the issues that were raised in that Indiana University report that I previously discussed. And to go about doing that report, they had monthly meetings. They engaged in listening tours all around the state. This was all, of course, supported by the State Department of Health. Um, they had coordinated communications. They engaged with folks from all over the state, but including the legislator, the governor's office, a broad group of stakeholders. In those monthly meetings, they covered lots of different public health topics, which not only were important to cover, but also needed to achieve the secondary purpose of educating folks on the difference between medical care and public health infrastructure. And very frequently, examples were used to sort of highlight how, you go to the doctor or you go to the clinic and that's one patient at a time, which is very different than trying to prevent, injuries in the playground, which doesn't have anything to do with the medical care system. But if we don't do enough of, we might overwhelm the emergency department with otherwise preventable injuries. Uh, those listening tour involved really trying to understand what stakeholders are feeling, what are they thinking. This was, of course, in the middle of COVID, or right after COVID, I should say, as COVID was sort of tailing off. And there was a lot of discussion. There was a lot of bi-directional conversation about how do we achieve some of the things that have been highlighted as deficient in our state. Uh, One of the things that the commission did really well was focus on the fact that public health benefits everyone, not just a single group. I think there was a misconception uh, of the fact that public health is really just for a certain segment of the population and it doesn't affect me, so why should I worry? I think there was not as much of a robust understanding that when public health is strengthened, the entire community could flourish. And so that kind of ties back to that economic prosperity, uh, where it was, I think, surprising to some that have spent a lot of time in public health to see how little people outside of public health intuit that relationship. That if you are not well, you cannot work. If you cannot work, you are absent. And if you are absent, that hurts business. And if you are present, you might engage in presenteeism, where you're not as productive as you can be because health issues, whether physical, medical, mental, behavioral, otherwise, are affecting your ability to perform. That then in turn affects the ability to attract new businesses to an area because healthcare costs might be higher than they should be had we invested a little bit more in prevention. So this cyclical nature between public health, population health, and ultimately business productivity and economic prosperity was not as well understood outside of the public health circles than I think even the public health experts expected. It's just so intuitive to some folks on the inside of that. But so the commission went on and really had a commitment to transparency and really engage with folks. Everything was available at the face-to-face meetings. There was also a live stream if you weren't able to come. There was time devoted for public comments. There was always summaries and agendas, either ahead of time or afterwards, available. The co-chairs did a really strong job at just engaging people and ferreting different things out so that it can get on the record. And I think at the end of the day, it created an environment where discourse could occur. You literally felt like people are actually talking about important things. And it was pretty gratifying to see unfold in real time.
Well, I want to discuss with you a little bit more about the dynamics and the issues that you all had to overcome. But before we get any farther in the conversation, I do have to make sure you tell us. So, what did this all achieve in the end? What level of funding did you get, and how did that compare to the past? I just want to make sure we're aware of how transformative this was.
Oh, yes. And I also want to say, and this hasn't been said yet, but is probably critical to set up the question that you just had. Indiana is a conservative state. Really always prided ourselves on our business friendliness. But in an era where, I think trust in science, trust in government, trust even in public health, especially on the heels of the pandemic, has probably been the lowest that I've ever seen in my lifetime, especially among conservatives. We were able to transform the public health system here with, as you mentioned earlier in the segment, 225 million new dollars in biennium public health funding. But this represented a 1,500% increase in our public health funding in the state. I'm pretty sure that's unprecedented in any time period for a given state, but especially in a time period where it seems like a lot of our colleagues in other states are still struggling with not making progress on some of these perennial challenges. And so it was pretty cool to be in a state that figured out a way to bring people together to talk about things. I should also mention that despite the fact that we are a conservative state, this was a bipartisan passed series of bills, both for the financial piece and the non-financial pieces of the recommendations that the commission made. Now, not all of the recommendations made it. I think the original ask was for a little bit more money, but ultimately, I think we feel pretty good that the solution that we have landed on that is committed to be, for more than just the next 2 years, is a very positive step forward, and hopefully will be something that other states can emulate or adapt to their needs.
Well, I want to talk about some of the hurdles you all overcame, but we'll do that after we take a short break. And we're back. I'm speaking with Nir Menachemi about Indiana's success in achieving a massive increase in public health investment. We just heard before the break, this is a 1,500% increase in state level funding for these efforts, and occurring at a time when, as we've noted, trust in science and public health has been hit pretty hard. So that seems like a good segue into a couple of more specific questions that I want to focus on, in part because we're having this conversation because we hope people around the country can learn from it. So one of the issues is partisanship, and you mentioned the general politics of Indiana. You also mentioned that the final legislation was bipartisan. So how did this process avoid devolving into a partisan fight over public health, as we have seen in so many other places?
Well, first and foremost, I think, at least this is my opinion, public health should be apolitical, not necessarily bipartisan. At the end of the day, whether or not we should have less kids injure themselves on the playground should not be a question of yes or no, but it should be a question of how, right? And so I think it becomes political when there are differences in opinions on how to achieve it, who should be responsible for it, and how they should go about doing that. And so one of the ways to try to make it apolitical was, and I give a lot of credit to some of my colleagues here in the state, including some of my co-authors who played a critical role in architecting this plan. But there was a specific decision to not use certain concepts that trigger political narratives. When you think about almost always, at least for the last couple of decades, the public health message has been critical of the past and critical of what we are doing wrong as a result of past experiences in this country and beyond. And that sometimes has the potential to trigger political narratives in our current kind of polarized environment. And so when a political narrative is triggered, you suddenly shut down the ability to even have an exchange of ideas. And so learning doesn't happen. Instead, you're encamping to figure out how to counter the argument so that when you get the microphone or you get to sort of speak, you could say why you disagree with that. And I don't think that was what the co-chairs wanted, and it's certainly not what the commission or the governor at the end of the day wanted. It was about discourse. And so instead of focusing critically on the past, we focused optimistically about what could be true in the future. And so things like, wouldn't it be great if everyone had a chance at all of the economic opportunities that the state has to offer, I think that suddenly opens up discourse to say, oh, well, how can we be better at that? Well, it turns out that if we can make people healthier, it might be helpful for these reasons. And so suddenly there's learning and bidirectional conversation as opposed to, I think what has happened way too often and increasingly happens, where you say something, you use a certain word, you use a certain phrase, and that signals to someone, this person is not on my political team. And it doesn't matter what they have to say. I'm just going to disagree because that's my responsibility to uphold the sanctity of my beliefs. And so we tried to steer clear of that, and I think it brought people together.
No, it makes a lot of sense. And even in a very different environment here at Health Affairs, one of the things our editors do is look for those kinds of phrases that are designed to signal which side you're on, as opposed to actually educate. So it's great to see that out in the real world happening to try to tamp down some of the uh, knee-jerk reactions on either side. I do want to spend a moment on a topic that I don't think gets very much attention, which is the county and state dynamics. You mentioned at the outset that one of the findings of the report out of the Fairbanks School is that that Indiana is more dependent on local funding than most states. And um, when you're sitting far away from these discussions, it's easy to sort of lose sight of the notion that they're actually politics around who does what and who pays for what and uh, who's responsible. So, can you say a little bit more about how the county perspectives were brought in and how issues of what could have been sources of attention between those levels of government were addressed in the process?
Yeah, so I think elected officials at the local level were absolutely critical to the entire operation. Besides having several of them on the commission itself, there was a very deliberate attempt to get engagement at the local level. So many of those listening tours kind of rotated around the state, both in urban and rural areas, where every time there was a meeting, there was a purposeful invitation of local businesses, local community leaders, local folks to have their voices heard, invited to explicitly, and also to engage in that bidirectional learning, where maybe they didn't know the difference about between some of the things that we talked about, like the medical system and public health. And so, to support that, there was also a lot of grassroots work to get folks to be uh, educated and hopefully supportive of the transformational changes that were being proposed. And so, one example of the grassroots effort was a public health day at the Capitol that literally had thousands of people come in, many who were told to wear, certain bright colored shirts to match the colors of the state health department in support of public health. I have these great pictures. I wish we could show them in the podcast venue, but there'll be other opportunities to show those pictures. But there was cheering and people overspilling. And so in the Capitol building. And so when legislators see that and they see this is something that businesses appear to want, this is something that their constituents want, this is something that by working with the counties and working with the cities, a lot of the mayors are saying, okay, yes, this is why we're having trouble attracting the, kinds of businesses to our areas that we want to. This seems like something we want to get behind. And so the state health department, IDOH, the Indiana Department of Health, met with dozens of stakeholders, some at the stakeholders' request, some as just reaching out and saying, we'd love to hear your ideas on this and we'd love the opportunity to chat with you. The governor even very publicly on a regular basis would say, participate in the process. Please go through in earnest, figure out if you can convince them or if you can sort of, let them see your point of view. We want to hear from you. And so having the governor be pretty visible about that, I think was encouraging and very helpful. Coupled with that transparency that I described, that the commission really conducted its business with, went a long way for building trust. And Alan, I talk very frequently about an epidemic, maybe even a pandemic that doesn't get enough attention. I call it a vitamin T deficiency and T here is trust, that affects members of our species pretty much anywhere and everywhere. And without trust, you just can't get anything done, not between two people, not between two organizations, not between two communities or two nations. And so a lot of time was invested in that trust building. And I think that goes a long way. And trust is usually the unsung hero that I think is behind a lot of transformational change. And I don't think it was different here. And so I want to stress that. In our state, to get back to your question, there hasn't been always a high level of trust between some folks at the local level and some folks at the state level. And so understanding the issues that have contributed to that and finding creative solutions to address those, I think, went a long way in getting to the finish line in this case.
Well, I'm tempted to end there, but I do have this question, and it may be so silly that I should have stopped. But, you know, I've worked in health policy for a long time, and I've seen a lot of reports written about a lot of problems, including about public health and how we underinvest and how we doesn't get the respect it deserves, and how it should be better integrated with the healthcare system. And report there, then the proverbial, it sits on the shelf. Someone writes it. It's a great report. It's accurate. It tells the story, but it doesn't lead to change. You begin this story in the article we've published in the journal with the report. You did a great job for me of describing, the major findings, but I can't believe it was the report that made this happen. So tell me, what is it, if you could put it all together, what is it that you think is the key ingredient for Indiana being able to leverage this report to actually achieve major change, as opposed to just being another report lamenting what you're not doing?
Excellent question. So I think the report was a catalyst. It was definitely not what was the secret sauce. If anything, the report leveled and built a knowledge playing field that brought everyone up to speed about the issues, instead of immediately devolving into, well, what about this and how about that, and can we get more data on something that's not necessarily relevant. The report was there. It was available publicly. It came from a resource that I think is trusted in the state to provide evidence around issues. Almost everything in there was based on hard data, so there wasn't a lot of conjecture. It was like, here are the facts, here are how they compare. I think that was an important piece, but I think it was really the marriage of political acumen and public health expertise in an environment that brought people together and really encouraged folks to roll up their sleeves and say, we can't continue to live with the current status quo if we are to aspire to achieve the things that we have collectively already committed to. And I think it's never really been framed that way in some of these other conversations. And I, like you, see many of these reports also, but I just want to say something about the Indiana environment. I've lived here now for 9 years. I've lived in many different states as an adult. I was born and raised in New York. I've lived in Florida and Maryland and Alabama. Indiana has a really special environment that makes it a little bit easier for these kinds of conversations to occur. It turns out that the largest city is also the state capital. And so a lot of the right people happen to be at the right place at the same time. That doesn't mean it can't be overcome in other states. It just means there's a slight easier leg up because these folks are going to the same grocery stores. They might be worshiping in the same, churches. They might be engaged in the same civic activities. They might be together with children in schools together. And so it makes those relationships a little bit easier to facilitate. And so I know that might not be super generalizable, but I think it just made it a little bit easier. And everything else that I've already said, I think sort of coming together simultaneously overcame some of the issues that the reports that you mentioned in other places might have been stymied by, ending up going on the shelf and not getting the traction that they need.
Well, I didn't write it down, but you said something like the marriage of political acumen and public health expertise. And that's a great phrase that I will carry with me as a description of what it took. So, Dr. Menachemi, thank you so much for telling the story. It is, as I noted at the outset, a story many of us heard about from afar. I feel like I have much more insight into what happened. Congratulations to you and your colleagues for what I think it's fair to say, a bipartisan success in investment in critical infrastructure. I appreciate your insights and your understanding and your contribution to all of this. Thank you for being my guest today on A Health Podyssey.
It was my pleasure. Thank you.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about A Health Podyssey.